And over to the third speaker of our session today, who is Dr Liz Bancroft. Liz is a researcher at the Institute of Cancer Research and has done a lot of work into looking at inherited mutations in prostate cancer and things such as stratified screening and testing for such patients. Again, Liz unfortunately couldn't be with us today, but she has pre-recorded her session for us so that we can listen to that. Thank you.
Hello, I'm Liz Bancroft and I'm here to talk to you today about the genetic insights into screening for prostate cancer. I'm sorry I can't be there in person, but I have put my contact details on the final slide should you have any questions about the contents of this session. So to give you an overview of what I'll be covering in this session, I'm going to talk about the genetic contribution to prostate cancer and what we know to date. And then I'm going to talk through 3 of our targeted prostate cancer screening studies that are using genetics within the screening algorithm. First of all, the IMPACT study, which is looking at prostate screening in men with rare genetic variants like the BRCA genes or the mismatch repair genes. The PROFILE study, which is offering screening based on family history or ancestry. And the Barcode 1 study, where we're using what's called a polygenic risk score to stratify men into different risk groups. Finally, I'll just touch on some of the future directions and challenges that we face in this area. So prostate cancer is the most common cancer in men in the UK, with 1 in 8 men affected with the disease. We see over 47,000 new cases per year, and we have well-established risk factors with age. The older you are, the more likely you are to get prostate cancer, as 2/3 of cases occur over the age of 70. Ethnicity, we see the highest risk in black men, and they have 2 to 3 times the risk of prostate cancer, but also double the risk of dying from prostate cancer when compared with white European men. Family history is also a risk factor where we know that risk increases with the closeness and number of affected relatives. The current status of screening internationally is that it is not recommended that we offer general population screening. Most screening is based on the PSA test, which stands for prostate specific antigen, but there's a lot of debate about what constitutes a normal PSA and how we avoid overdiagnosis and overtreatment of prostate cancers that will never cause any problem within a man's lifetime. There's also a lot of ongoing research looking at different methods of MRI and as well as different methods of doing biopsies, either systematically or targeted when used in combination with MRI, to determine the best way of diagnosing clinically significant prostate cancers. And this is really the premise of our research. We're looking at different ways of stratifying screening and approaching screening for men known to be at higher risk. In terms of genetic predisposition to prostate cancer, there's really 2 areas of interest. Firstly, in germline rare variants, where it's well established that men who've inherited a mutation in, for example, the BRCA2 gene, have a moderately increased risk of prostate cancer. There's a number of other genes, particularly DNA repair genes, where there's increasing evidence of a role in the development of prostate cancer, and this is particularly interesting in terms of targeting treatments and therapies to men who go on to develop the disease. Secondly, we're interested in common genetic variation, where there's now about 260 single nucleotide polymorphisms, or SNPs, which each individually only have a small impact on prostate cancer risk, but that are thought to act multiplicatively. So we're able to calculate a person's polygenic risk score for their future risk of developing prostate cancer based on the calculation of their SNP profile. So for men who fall into the top 1% of the risk profile, they have about 5.7 times the risk of the average man, and those in the top 10% have about 2.7 times the risk of the average man. So you can see you can really start to stratify out groups of men whose risk is significantly greater than average to consider screening. As well as this, about 40 of those SNPs have been associated with aggressive and early onset disease. So as our knowledge develops, we'll be able to determine ways we can use this information clinically. As I've already touched on, most of our research is focusing on how we're using targeted screening in these men we've identified as being at higher risk. But it's also important to mention that this then of course has wider implications for the family in terms of being able to offer risk assessments and cascade testing. But also for men who've already developed prostate cancer, there's increasing evidence of targeted therapies that can be used, particularly within the metastatic context. For example, PARP inhibitors are now licensed in both the USA and in Europe for men with metastatic castration-resistant disease who have mutations in BRCA1 and BRCA2. We also have some research ongoing to evaluate the use of carboplatin in men with metastatic disease, and immunotherapies are increasingly being used in men with mismatch repair gene mutations, both somatically and in the germline. So to focus in a little bit more about risk of prostate cancer associated with some of the rare variants, for BRCA1, the relative risk of prostate cancer is thought to be about 2.35, which translates into an absolute risk of about 29% by age 85. For BRCA2, the relative risk is 4.45, with an absolute risk of about 60% by age 85. Importantly, BRCA2 carriers have significantly worse survival, higher Gleason scores, and a lower mean age at diagnosis. For men with mutations in the mismatch repair genes, which predispose to a syndrome called Lynch syndrome, which is characterised by predominantly bowel, endometrial and ovarian cancers, there's also increasing evidence of an increased risk of prostate cancer, with some reports of that being as high as 5 to 10-fold. The risk is primarily associated with mutations in MSH2 and MSH6, and there's reports of, similar to BRCA2, of young onset and more aggressive disease. These reports of an increased risk associated with these genes led on to the development of the IMPACT study. The aims of IMPACT were to establish an international targeted prostate cancer screening study for men known to carry these variants, particularly in BRCA1 and BRCA2 to start off with, and later we established a cohort of men with mismatch repair genes. The aims were to determine the sensitivity and specificity of PSA screening, the incidence of raised PSA in abnormal biopsy, and to understand more about the pathogenesis of prostate cancer in men with these mutations. And so IMPACT has been a large international effort, and the aim has been to recruit the target populations as listed there below. Our control group are made up of men who've had a predictive negative test for, so there's a mutation known to be in the family and they don't carry it. It's important to mention that the IMPACT study was designed back in 2004, which was before the routine use of MRI in the prostate cancer diagnostic pathway. So men recruited to IMPACT underwent an annual PSA test, and if the PSA was below 3, they discontinued with annual screening. Where PSA is above 3, this generated a biopsy, and depending on the outcome of that biopsy, either they were then treated for prostate cancer or put back onto annual screening where the biopsy was benign. If we found any intermediate results such as high-grade PIN or ASAP, the biopsy would be repeated after either 3 or 6 months. So far we've completed 4 rounds of screening in our BRCA1 and 2 mutation carriers. This has been involved just under 3,000 men, and the biopsy frequency has been around about 5%, so that's quite reassuring that we're not over biopsying these men. We've diagnosed 112 cancers, and the positive predictive value of biopsy, so the chances of us finding cancer at biopsy where PSA is over 3, is higher in our BRCA carriers compared with the controls, and the cancer incidence is also significantly higher in our BRCA2 carriers compared with controls. For BRCA1 carriers, there's no significant differences when compared with their control group at present, and further screening rounds will determine whether there is an increased risk of prostate cancer in these men. Looking at the cancer characteristics, and I'm sorry this is quite a busy slide, so if you just look at the 3 red boxes, you can see that the BRCA2 carriers are generally diagnosed younger than the BRCA2 controls, and that they have much higher chance of having intermediate or high risk cancers diagnosed at biopsy. And just to summarise what we found so far, in this cohort after 4 screening rounds, there's a higher cancer incidence in BRCA2 carriers, they're younger at diagnosis, and they have significantly more aggressive tumours than non-carriers. So therefore from this we've advised that annual PSA screening should start from 40 in BRCA2 carriers We haven't seen the same in BRCA1 carriers, and we need more follow-up to determine how they should be managed clinically. In our Lynch syndrome cohort, the results of the baseline screen, so this is the PSA the men are having at study entry, we have had just over 1,000 men recruited. The biopsy frequency is very similar to that seen in the BRCA cohort of about 4%. We've detected 18 prostate cancers so far, 13 in MSH2 carriers, 1 in an MSH2 control, and 4 in MSH6 carriers. In terms of the prostate cancer incidence, you can see it's significantly higher in the MSH2 carriers compared with non-carriers, and equally significant in the MSH6 carriers compared with the non-carriers. If we look at the positive predictive value of biopsy, so the chances that we're going to see cancer at biopsy, in the overall cohort it's 51%, but if we break that down by mutation status, it is significantly higher, 72% in the MSH2 carriers compared with the control group, and in MSH6 carriers significantly higher than their respective control group. I would just caution this and say that so far there's been relatively small numbers of biopsies and cancers, so we do need to follow that trend up to see how that bears through the course of the study. So all men in this cohort are going through 5 years of screening, which will be complete in 2024. And just to draw your attention here on this slide, there is a great degree of T2C and T3 disease being diagnosed in these men, so the vast majority falling into the high risk category when using the NICE guidelines. So these are important cancers to be detecting. So to summarise our findings from IMPACT so far, we have recommended that all BRCA2 carriers aged over 40 should have annual PSA screening using that PSA threshold of 3 to indicate biopsy. The European screening guidelines have been updated to include this recommendation, and we're working with the UK Screening Guidelines Committee to consider updating their guidelines. Off the back of our analysis of the Lynch syndrome cohort, we feel there's a strong case for recommending annual PSA screening for MSH2 and MSH6 carriers from 40 using that same threshold. What we don't know and aren't able to evaluate from IMPACT is the use of MRI in this screening algorithm, and that is research that is still very much required. We have got a study starting up this month to address that question, but it will be very important to understand more about the use of MRI associated with genetic risk. So moving on to tell you a little bit about how we're using common genetic variation to inform prostate cancer screening, I'm firstly going to tell you about the PROFILE study. So the aim of PROFILE is to investigate the role of targeted prostate cancer screening in men at higher genetic risk. And for this, we've got 2 cohorts. We've got a men with a family history of prostate cancer, and we've got a cohort of men of Black African Caribbean ancestry. All men are aged between 40 and 69, and the primary endpoint is to determine the association of MRI and biopsy with polygenic risk score in these men. For this study, we are recruiting men based on ancestry or family history, not on their SNP profile. But what we're going to do during the course of the study is analyse their polygenic risk score and look back retrospectively to see whether we could have determined from their polygenic risk score which men would go on to develop prostate cancer. So the way that we are approaching this is all men are invited to undergo prostate MRI and biopsy irrespective of PSA level. And if cancer is not detected at biopsy, then men are followed up with a PSA test for 5 years. The key questions we're looking at are whether if we were to add in genetic profile, MRI and biopsy into this algorithm, would this be an improvement on age-related PSA screening? What we hope to find is that genetic profiling will result in detection of a higher proportion of clinically significant prostate cancers than using an age-based screening approach. And we aim to find out whether genetic profile is predictive of biopsy outcome and whether it also can predict for clinically significant disease. So far we've recruited 300 of the 350 men in the family history cohort and 135 of the African Caribbean cohort. As I mentioned just before, we have recently launched a new cohort of men with rare variants, so this is very much leading on from the IMPACT study to try and evaluate the use of MRI and biopsy irrespective of PSA level in men with those rare variants. So that is something we're embarking on shortly. We undertook a feasibility study before we launched the main profile study, and for this we recruited 100 men with a strong family history of prostate cancer, and they all underwent prostate biopsy. 50 of the men also underwent MRI prior to their biopsy. And what we found from this was that 24% of men already had evidence of prostate cancer, half of which actually needed treatment in accordance with the NICE guidelines. The average age at diagnosis was 59.7 and median PSA was 5.4. We found that the polygenic risk score was higher in the men with cancer, but particularly where PSA was less than 1. Overall age, family history and PSA were more predictive of prostate cancer than polygenic risk score in this feasibility study, but I must mention that we only used a polygenic risk score based on 71 SNPs because that was what was available to us at the time. So it'll be interesting to see in the main study how our profile of 260 SNPs is better able to predict for biopsy outcome. So the final study is the Barcode 1 study, where we're using common genetic variants in a prostate cancer screening algorithm. Now, unlike the profile study, we're actually doing the polygenic risk score up front and using the result of that to determine who we're going to be inviting in for screening. So we've approached over 5,000 men recruited by GP practices of white European ancestry, aged between 55 and 69 years, and we are using a SNP profile of 170 SNPs to calculate polygenic risk score. And so for those men that fall into the top 10%, we are then inviting them in for an MRI and biopsy, irrespective of their PSA level. The endpoints are to investigate the uptake of this and to see whether men find it acceptable to be stratified based on their genetics, and we want to correlate polygenic risk score with both MRI outcome and with biopsy outcome. So we undertook a pilot study of 300 men funded by the ERC, and we found that there was a 26% overall uptake when we were approaching men via their GP practices. We had a good rate of return of the saliva kits for those men who had expressed an interest, and from the 300, 25 men were identified in the top 10% of that polygenic risk score. 84% of those men took up our offer of having an MRI and biopsy. So from this we determined it was feasible, acceptable and safe to carry on with the main study, which opened in April 2019. We had an expression of interest from over 8,000 men who we screened for eligibility, sent the saliva kits out to, and we've had 6,400 salivas returned to us. For the men in the top 10%, we've got around about 500 men being contacted. We've completed 200 MRIs and 100 biopsies to date and diagnosed 41 cancers. So it'll be important to follow up the rest of this cohort and then look at what kind of cancers we're seeing in these men and work out whether the polygenic risk score has helped us identify those with clinically significant disease. So just to focus on some of the future challenges and summarise where we're up to. Who will we screen? Will we get to the point where we can use risk stratification based on things like ethnicity, family history and polygenic risk score to be able to confidently identify men who perhaps can have low intensity or even no screening? And will this help us avoid all the harms of using PSA screening, such as overdiagnosis? Will we be able to confidently pick out those men suitable for high intensity screening to detect those clinically significant cancers that we need to know about? For many years, PSA has been the gold standard biomarker, but there is lots of interest in new biomarkers and lots of research going into that, as well as, of course, the imaging and biopsy techniques being perfected. Will we get to the point when genetic testing using polygenic risk score can become mainstream for all men in the general population to help risk stratify them? Will this be acceptable to the men being offered this test? And in terms of mainstream testing of rare variants in men with prostate cancer, we hope that will become a reality over the coming years as more and more targeted therapies become available. And this, of course, will consequently increase the number of relatives undergoing predictive testing who then want to know what sort of screening they should undergo. And thinking about all of this in the context of the health service, obviously we need to have training for healthcare professionals and also the adequate information support for patients going through genetic testing if this is to become standard practice. So that's everything I wanted to share with you today. I just wanted to acknowledge that this work is, of course, a collaboration of a huge number of people, and so just to acknowledge my colleagues, but also, of course, importantly, our funders of this research. And I'm more than happy to be contacted with any questions you may have about the contents of this session,